discussing about the journals to this month, and there are quite interesting articles which have come with regards to a mixed bag in pediatric endocrinology. Why really do we need to do a literature review? That is a key question which often we will ask, and often if we do not look into the literature, we will be left behind in terms of what new developments are happening. So the 4 points we want to look at in a paper which is coming is it valid? Is it generalizable? Particularly if it's been done in a different environment, is it valid and generalizable for our population? Is it a novel work which warrants a change in our practice? So this is what are the 4 criteria that we'll try to assess all the 4 journals and try to see if we need to change our practice from that perspective or not. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of innovative resources and courses. We have got fellowship programs and diploma programs in pediatric endocrinology. There are 3 programs which we run every month. One is a grand round, then this is journal club, and then we've got a PG lecture series which is run from that perspective. There are publications and mobile applications. So many patients who have got dysglycemia in the setting of obesity, individuals in which you have got variations in sugars, which is the best parameter to identify that? Is it the fasting glucose, the 2-hour glucose, the HbA1c, or some other parameter is a challenge? Because if you are able to identify those who have dysglycemia, you can intervene further. So Dr. Manoj will talk about this study which compared the various tests to identify dysglycemia in children and adolescents.
In India and all over the world, obesity is increasing dramatically nowadays. Every 4th obese children in the USA and India has a obesity complications. And we have to think about the complications because obesity comes with the all complications like type 2 diabetes, cardiovascular problem, raised SGPT level, and altered lipid profile. So if we don't treat at the right time, then it can cause the type 2 diabetes and cardiovascular complication. So this study has been done in the USA, Michigan University, and the paper is about to publish in 2023. So if we start about the background of the study, then for the picking up the dysglycemia in the obese child, we have now in India we are using now 3 most parameters that we are using. One is HbA1c, fasting blood sugar, and OGTT. Among all the 3 criteria have the drawback and positive points. What are the positive points for the HbA1c? HbA1c is easy to do. No need of the fasting for the HbA1c, but there are low sensitivity and specificity for the children perspective, and it affected by the RBC turnover. So whenever child has a hemoglobinopathy, the HbA1c has a no value. Second, the fasting blood sugar and OGTT. So fasting blood sugar has a low sensitivity and OGTT has a low reproducibility. Here, reproducibility in terms of the precision, because if we repeat the sample it again, then the result would be the different. So it would be not in the same precision criteria. And there are the limited data of the 1 hour glucose load in the Indian perspective. And what about the other non-fasting parameters rather than the HbA1c? So if we talk about the fructosamine and 1,5 N-hydroglucitol, then it is not, the data is not available in the Indian's perspective and all over the world also for the picking dysglycemia. So in adult, there are some studies has been done which shows that there are the higher non-fasting level of the HbA1c and RBC is linked with the high risk of the future development of the type 2 diabetes. So taking this study in our mind, and in the pediatric perspective, there are the limited data, and during the puberty, because puberty is a state of the insulin resistance where insulin sensitivity is high, very less. So in this at this point, the diagnosis of the dysglycemia is very difficult. So if I start my journal club, then what are the objective of this study? The objective of the study to evaluate the prospective test performance or the non-fasting blood sugar like random blood sugar, HbA1c, 1 hour OGTT, fructosamine, and 1,5 N-hydroglucitol to identify dysglycemia in obese children. And the type of study was a longitudinal cohort, and the study duration was 1.1 years, and the total 4 visits was included in the studies. So what are the inclusion and exclusion criteria? So they have considered overweight and obese, more than 85 percentile of sex and age, and the age group was 8 to 17 years of age. Here I want to highlight that they have mentioned overweight also. And what are the exclusion criteria? Any known case of the diabetes or medication that altered the glucose metabolism, and the pregnancy was excluded. So what are the study design? Baseline, they have done they have taken anthropometry data, vitals, and the basic laboratory parameters. If I start according to study, then at the visit first, they have taken this fasted sample, which contains the fasting blood sugar, HbA1c, 1 hour OGTT, 2 hour OGTT, and the minimum fast for that required was 12 hours. After 1 to 3 weeks, to see the reproducibility, they have given 50 gram of the glucose, and they measured 1 hour OGTT, not 2 hour OGTT.
Like the pregnancy in which they do a glucose challenge test, something like that. So I think the reason why this study is being done is that doing a proper OGTT with a fasting sample will be difficult. So what they're trying to say, okay, I don't want to do a fasting in PP, I want to look at something else. Patient comes, I'll measure HbA1c, I'll measure AIG level, I will measure GCT and get an immediate diagnosis. So are they considering the OGTT as the gold standard? What's the gold standard of the outcome?
HbA1c.
HbA1c is the gold standard for it. Okay, carry
on. And the patient has called for the follow-up for the visit 3 and visit 4 after 1 year of the duration. And at the visit 3, they have repeated the oil sample which they have taken at the first visit, like glucose fasting blood sugar, HbA1c, fructosamine 15 Ag, and 1 hour and 2 hour OGTT, and the visit 4, they have repeated the fasting blood sugar and the 2 hour OGTT. Here, criteria for the picking of the dysglycemia was according to ADA guideline, which contains the HbA1c level more than 5.6, the fasting blood sugar more than 100, and the OGTT more than 140. And if we see the baseline data, then they have included 176 number of the patient total. Here, the number of the female were higher than the male, and they have included 58% of the obese patient, while among them 43% were overweight. So here they had a mixture of the overweight and obese. If we see about the pubertal status, then the most of the children in the male and female tenor state, they were the pubertal or the post-pubertal. And at the baseline visit 4 and visit 3, the 18% patient have an abnormal HbA1c, and 28% patient have abnormal glycemic parameter or HbA1c. So if we see the outcome, what they want to see, they have to taking this all the data into consideration, they have created the ROC curve, and they have measured sensitivity, specificity, positive and negative predictive value of individual parameter. So if I start about the outcome, then
to what?
About the baseline parameter in comparison to predict the final outcome.
So the gold standard is the final outcome and not the HbA1c. So final outcome is whether they have dysglycemia or not. So this is very important to remember. What they're trying to do is that what this is telling now and what is going to happen 1 year later. This is a very, very important parameter.
Okay. So here first I want to discuss about the reproducibility. So they have compared the result of visit 3 and visit 4. So at the visit 3, 6 participants of impaired fasting blood sugar. Among them, 5 became normal. So the reproducibility of the fasting blood sugar was poor according to this study, and to normal participate with the fasting blood sugar, they develop impaired fasting blood sugar. If I talk about the oral 2-hour plasma blood glucose test, then at the visited among 8 participants of impaired 2-hour OGTT, 5 became normal, and two normal participants become abnormal at the duration of the 1 to 3 week. So it is suggestive there are the less reproducibility of the fasting and OGTT. And what
measure HbA1c twice also. They should have checked that also, because then you will get to know really whether the reproducibility, because we're talking about minor number. We're talking about HbA1c of 5.6 and 5.8. That will make a big difference. So that probably will also be an important factor to look at.
And here
glucose variability anyway 10% is within the mean absolute relative difference of 10% is considered to be a reasonable number. So if somebody was 105 and he becomes 95, this is within the coefficient of variation. So you can't say that there is a poor reproducibility. Every of the parameters will have that.
But about the OGTT also reproduces.
Yes, so 10%. So glucose variation. So somebody is at 140, he would be 126 the next day because 10% is within the range. So that value also you have to consider. This is part of the glucose test. Same about HbA1c, we need to know how much is the reproducibility.
And at the outcome, 5 to 10% normal baseline glycemia participate at visit 1 become abnormal at visit 3 and visit 4, and 40 to 78% of patients with the abnormal baseline parameter remained abnormal. So if I
progression was only 10%.
Yes. Visit 3, they have done all the parameters.
Not at visit 4. Visit 4, they did not do. So 3 and 4 is just like 2 weeks apart.
1 to 3 weeks.
So what we are seeing, just hold on. What we are saying basically is that if you look at follow-up, most patients who were abnormal, they remained abnormal. But there were few who were normal became abnormal on follow-up. So there was a progression happened in around 10% of cases. And what was the baseline rate of dysglycemia? How many had?
Sir, baseline rate of the dysglycemia, if we compare
less than 10%. So 161 and 15 basically were abnormal. So there was not a huge. So it was like because a lot of overweight patients were there, you're looking at around a figure of around 10% prevalence of this. Carry on.
So if we compare about if we see according to the ROC curve, then at the first column, it was a it was the glycemic parameter in the comparison of the HbA1c random blood glucose 1 hour glucose challenge test. The cutoff point for all three for the baseline HbA1c random glucose and 1 hour OGTT shows the similar result. The result, the point was around 0.7, 0.68 and 0.78. So they did the similar performance for the predicting glucose dependent glycemia parameter at the final outcome.
But these are not very good. 0.7 is just the tip area under the curve as far as the ROC curve is concerned. So they're not correlating very well.
If we talk about the final HbA1c level, then the baseline HbA1c level has predicted a good outcome in terms of the cutoff point of 0.93. About the RBS and about the 1 hour challenge test, they have shown only 0.60, 0.67 and 0.57. If we talk about the baseline combined glycemic parameter, then again HbA1c did the good performance, with the cutoff point of 0.81. And where the other cutoff was not good enough.
So what are you telling about is basically that if we look at somebody at the start and we look at HbA1c fasting 2-hour value and you want to predict what is going to happen after 1 year, HbA1c has got the best diagnostic accuracy. That's what you are saying from this regard. And did they come up with a cutoff?
Yes, cutoff. That I will discuss in subsequent slide. So if we compare about the whole table, then HbA1c did the good performance in terms of the 0.7, 0.93 and 0.8 cutoff, 0.81 point. And if we compare about the fructosamine and 1,5 N-hydroglucitol value, then they did the poor performance. The cutoff point was less than 0.5. So it is, the taste was not good and not bad. So it was like coin.
It was worse than
Flipping
the
a coin.
0.45 is worse than the point.
So they didn't show the good nice result for the prediction of the dysglycemia. So if we talk about the sensitivity and the specificity to outcome of the glucose-defined dysglycemia, HbA1c had a low sensitivity around 25% with the higher specificity of the 96% if we take the cutoff of 5.7%. But if we reduce the cutoff from 5.7 to 5.4, then the sensitivity is double, but it is not again very good, like 56.
Are you happy with this?
No.
What does it mean?
No.
What does it mean in simple terms?
Means only 56% patient was able to pick up by the HbA1c level of.
So if we had 100 people who had abnormal fasting glucose or other glucose, right, 44 will be missed. So there's no point in having that. So that means that is a different thing. HbA1c is a different thing. Probably this is what is coming on, because you will not. It's a screening test. You want to have a high sensitivity. 56% sensitivity is of no meaning. Yeah, carry on.
So here they have mentioned that sensitivity is very low, but specificity is high. So to 96%.
What is the point?
Okay.
So they will mention, but you have to tell yourself what does it mean. What about the other things?
So if we take as the combined outcome as a parameter, then HbA1c threshold of 5.7 for the predicting the combined outcome, which contain the fasting, 2 hour and the HbA1c, then the sensitivity is only 29% with the specificity of the 98. But if we take the cutoff of 5.4, then also sensitivity become not huge, like 64%, and specificity is 81%.
So what it basically tells you is that if HbA1c is high, then you are okay. There is a problem. If HbA1c is low, you can still have problem. So this is the main rule. So if your HbA1c is above 5.7, you can assume that 98% there will be a problem. So I think the role of HbA1c would actually be in ruling in a problem. If HbA1c is high, diagnosis is made. So it's more like a confirmatory test rather than a screening test.
So if we talk about the random blood glucose value, then that had a severe low sensitivity at the threshold of 100 milligram per deciliter. So if we cut off this 100 is abnormal, then also the sensitivity is only 53 to 61%. And if it at the 90 milligram per deciliter, specificity is 58 to 66%.
So they did not look for 70 or something.
What's that? No.
So they did not look for 70 because it doesn't make sense. You have 100
is
very low. There's no point looking at 90. Then how many? You're talking about 90. How many of them will be above? Everybody will be above 90. Then you start getting unnecessary worked out. So what they're saying is that random sugar is basically useless in terms of evaluation. Next.
So now we compare about the 1 hour glucose tolerance test. Then it has shown the lowest sensitivity among all at the threshold of 110, which is very low. So the sensitivity is 53%, 39%, 49%, and specificity of 85, 84, and 85 in to the predicting value of for the glucose-defined dysglycemia, elevated HbA1c, and abnormal glucose level. So in summary, the it has a low sensitivity.
So it is not good.
So HbA1c remained the strongest predictor of the combined outcome of glucose-defined dysglycemia or elevated HbA1c.
But it is also not good enough. So what they are basically saying is that you have to do everything. You have to do a fasting. You can't miss the fasting value. That is very important from that perspective.
So here, if I conclude this study, then HbA1c had good specificity but very low sensitivity, and the RBS 1 hour OGDT may be given can give additional benefits if the HbA1c is not possible, where the hemoglobinopathy is present. And if we talk about the fructosamine and 1.15 Ag level, then it showed the poor prediction for the glycemic, for the dysglycemia prediction. So for the evaluation of this study, the outcome, what are the limiting point in this study? They have seen the combined outcome for the fasting and 2-hour OGTT. It should be a different outcome for the these two different pathophysiology. And the population selected, what the population they have selected, they combine the obese and non-obese patient, overweight patient. And pubertal assessment here was self-reported, and some were reported by the parents also.
Not make a difference. The major problem was that you were studying in an overweight age group, in which the prevalence of this disease will be very less. If your prevalence is very less, then all these sensitivity specificity will have limited use. If they had focused only in obese, and I assume that only obese would have had all these problems, the prevalence would have doubled. Then you will find a better differentiated feature.
And they didn't take into the consideration of final BMI changes, which is not linked with the outcome. So if we see the generalizability, then the cost is an issue in the Indian perspective, because in Indian OPD, we can't do this investigation for all the patient. And here 1 hour OGTT has a limited value because of the reproducibility issue, and the role of the fructosamine is in this setting, it is a questionable.
So I think this was a good study, which is basically looking at a parameter of what is the best predictor which is going to happen over 1 year. So what does it mean? That if you find somebody who has a high risk, you will start doing more intervention. Maybe think of metformin and other parameters. But again, the problem is that they are not able to get the right outcome. So you are suggesting that we should have for only obese individuals and do more parameters to look at. So now we have had discussions about 4 very important topics. One was about the use of a novel drug for the management of childhood obesity. Then we talked about the effect of maternal thyroid dysfunction on outcome of neurodevelopmental. We talked about the various parameters, and what we found was that it may be good to actually stick to a fasting PP and HbA1c rather than go ahead with other parameters. And CGM initiation at diagnosis would be a good parameter. All of you can go and have a look at our website, the courses, and the mobile application.